topic for discussion now is calcium metabolism and parathyroid hormone. As we all know, calcium is one of the most important minor trace element within the body, which is helpful for various functions of the body, various physiological functions of the body. For example, it is helpful or essential in both structural and also in functional physiological processes of the body. How it is useful in structural? Because it gives hardness to the bones, thus it gives a structure or a skeletal structure to the body, and it is also very much essential in neuromuscular functioning because neuronal cells are very susceptible for the calcium. So let us go in detail about the calcium metabolism and various hormones or various other factors which are responsible for the homeostasis of the calcium, and let us also see about parathyroid hormone and how it actually helps in calcium metabolism and its other functions also. So as we have discussed, calcium is very much important for contraction of muscles. It is useful for blood clotting because it is one of the clotting factors, and it is also helpful for transmission of nerve impulses. What is the normal value of calcium within the ECF, that is extracellular fluid? The normal value is 9.4 milligram per deciliter, which is the normal value of the calcium in the extracellular fluid. It is only 1.1% is in extracellular fluid and 1% is in the cells, and rest all is present in the bone. That is about 99% of calcium of the body is present within the bone. Hence, bones are called as the reserves or stores of calcium within the body. Okay, and calcium in plasma is usually available in three forms. One is conjugated form, where it has been associated with the proteins of the plasma proteins, and then we also have unconjugated form, where it is combined with anionic materials, and we also have something called as diffusible or ionic form of calcium, which comprises about 55% of the total calcium within the ECF, and this is the one which is useful for maintaining the whole homeostasis of the whole calcium homeostasis. This form of unionized or diffusible form of calcium is essential there. And as we already discussed, neurons are highly susceptible for any change in the calcium, may it be hypercalcemia or hypocalcemia. Hypercalcemia is nothing but increase in calcium levels than the normal range, whereas hypo is nothing but decrease of calcium levels than the normal range, that is about 9.4 milligram per deciliter. In this hypercalcemia, what happens? There will be progressive depression of the nervous system, whereas in hypocalcemia there will be excitation of the nervous system. Coming to the various functions of calcium, as we already discussed, calcium is very much important for maintaining the hardness of the bone. It is the most important inorganic component of the bone, calcium as well as phosphate, and in teeth it forms a microstructure. It is essential for formation of microstructure of teeth, especially for the calcification of the tooth matrix. Okay, and this also is useful for calcium is also essential for stabilization of cell membrane and its permeability, and in heart, for pacemaker potential, calcium is very essential. It also acts as secondary messenger, and calcium is essential in case of various enzymatic activities in the product in the structure of enzymes themselves, and also in coagulation cascade calcium plays a very important role, and we also have for neuromuscular functioning also calcium is very much important. Now coming to calcium homeostasis. What is homeostasis? Homeostasis is nothing but net gain or loss of calcium within the body for a prescribed time period. For that particular time period, what is the net gain and loss of calcium within the body is nothing but calcium homeostasis. And this calcium homeostasis depends upon three important factors. One is the calciotropic hormones. There are three calciotropic hormones which include parathyroid hormone. We have vitamin D. Vitamin D is also considered as hormone here, and we also have calcitonin. And we also have three targets. Those three targets include bone, gut and kidney, because these are the three areas where actually calcium reserves or calcium absorption and calcium excretion. These three areas play a very important role in calcium regulation. And we have three bone cells which are also helpful for calcium homeostasis. They include osteoblast, osteoclast and osteocytes. Coming to the metabolism of calcium. So what are the steps that actually are involved in calcium metabolism? We have calcium absorption, We have calcium regulation and calcium excretion. Coming to calcium absorption, normally we have something called as RDA, that is recommended dietary intake. Intake is about 0.6 to 0.8 milligram per day, and gut absorbs the calcium and it reaches the ECF, that is extracellular fluid. In the ECF, calcium is again in three forms, as we have already seen, as free ions, ions bound to proteins, and as diffusible complexes. Now from this ECF, these anionic form will go and attach it to the bone, and from ECF to kidneys they are actually filtered, secreted and reabsorbed. This is in just how the calcium regulation actually takes place. Now coming to recommended dietary intake of calcium. Calcium is very much essential for growth, especially in pregnant women and also in children of growth period, of growth phase. In adults, the requirement is about 500 to 800 milligrams. In pregnancy and lactation, it is usually more in number, because in lactation, calcium is very important for milk production. So in lactating mother, about 2000 milligram of calcium is required per day, and in pregnancy 1500 milligrams, in growth period 800 milligrams, which is almost equal to adults, and in infants 360 milligrams of calcium RDA is recommended, that is recommended daily intake. Now coming to various dietary sources of calcium. We have various dietary sources which includes milk and milk products. We have eggs and fish. In fish, salmon is very rich in calcium. We have vegetables, fruits, fortified bread, nuts. We also have fortified milk, and hard water is also rich in calcium. Now coming to absorption of calcium. What are the factors that are actually controlling absorption of calcium? These factors, the factors which are actually acting on the mucosal cells and those affecting the availability of calcium and phosphates in the gut. The factors acting on the mucosal cells are vitamin D. Vitamin D helps for calcium absorption in the gut. And we also have effect of previous calcium intake and calcium stores. Even these also play an important role in knowing the calcium regulation within the body. Pregnancy and growth and parathyroid hormone. Coming to intestinal absorption of calcium, usual rates of intake as we discussed are about 1000 milligram per day, or that is nothing but about 500 to 800 milligram per day in adults. And this vitamin D helps calcium absorption in the intestine. About 35% of ingested calcium is usually absorbed. That means how much ever calcium you take, only 35% of the total dietary intake is being absorbed from the gut, okay, from the intestine. So what are the factors that are actually affecting the availability of calcium in the gut? pH of the intestine. pH of intestine is very much essential for calcium, absorption of calcium. And if patient is on chronic antacids where the pH of the stomach is not maintained, calcium absorption can be impaired in those cases. Amount of dietary calcium and phosphate obviously, and oxalates, phytic acids and phytates will also affect the availability. It decreases. Fats, proteins and amino acids increase the absorption. Carbohydrates also help in increasing the absorption along with bile salts. There is something called as parathyroid hormone. Parathyroid hormone is actually a hormone secreted by parathyroid glands, which is actually present posterior to thyroid. These parathyroid glands are 4 in number. These parathyroid glands have 2 cells which include chief cells and oxyphil cells. Chief cells are those which secrete the parathyroid hormone, and oxyphil cells are those which will store this parathyroid hormone. Parathyroid hormone usually stimulates the formation of 1,25-dihydroxycholecalciferol, which is nothing but our vitamin D, the active form of vitamin D. So, for vitamin D, parathyroid hormone is very much essential. In turn, vitamin D is also essential for calcium absorption. That is, parathyroid hormone is thus both directly and indirectly affecting the regulation of calcium. Coming to 1,25-dihydroxycholecalciferol, which will then act on the intestine and increases the calcium absorption. So, coming to calcium homeostasis, it is nothing but maintenance of the constant free plasma calcium concentration all the time. Maintaining that calcium concentration of 9.4 milligram per deciliter in the extracellular fluid or within the plasma is nothing but the calcium homeostasis. For this, it depends upon the rapid exchange between the bone and extracellular fluid. For this rapid exchange of calcium, whenever the extracellular fluids calcium levels are low, bone gives out the calcium because of osteoclastic effect. Once the the bone from the calcium from the bone is transferred to the ECF and the calcium levels in the ECF is raised, then that within the bone is been stopped. The resorption within the bone is stopped. So for this activity of the rapid exchange of calcium from bone to the ECF, it will involve some hormones, that is nothing but PTH, that is parathyroid hormone and calcitonin. So it is calculated by deduction of calcium in feces and urine from the calcium taken in the diet. Positive calcium balance is usually seen in growing children and negative calcium balance is seen in adults, especially in those who are suffering from osteoporosis. Now this is a picture showing how many cells of calcium occurs. As we know, the normal calcium level 9.4, let us assume it as 10 mg per deciliter. Whenever there is an increased calcium level, what happens is thyroid gland releases calcitonin. Calcitonin is an antagonist for parathyroid hormone. Whenever there is release of calcitonin, what it does, it will decrease the parathyroid hormone levels in the body. When the parathyroid hormone levels are decreased, this will cause reduction in the osteoclastic effect. So, as the osteoclastic effect is not happening, there will be decrease of the transfer of calcium from the bone to the ECF. So, and also it will cause it will also decrease the calcium reabsorption from the kidneys. This in turn will decrease the calcium level within the blood. Thus, it comes back to the normal stage. Once it has reached the normal stage, it will go back as a feedback mechanism and the thyroid releasing calcium will be stopped there. Now, for example, if the calcium level has decreased than the normal level, then it gives a signal to the parathyroid glands which will release parathyroid hormone. As we all know, parathyroid hormone has its effect on rank L cells, that is rank cells will actually combine to form rank ligand, which has an osteoclastic effect, that is which will stimulate the osteoclast, where the osteoclast starts releasing calcium from the bone. In the kidneys, what happens, this parathyroid hormone will go and act such a way that calcium is reabsorbed from the kidney and is again sent to the plasma. Here, because of this calcium from the bone and from the kidney is entering into the ECF, and also calcium absorption in the small intestine is increased because of vitamin D synthesis, there will be calcium level increase in the blood again, leading to normal calcium level. Once the normal calcium level is reached, it will again go back with a biofeedback mechanism, giving a negative signal to the parathyroid gland, thus stopping the release of parathyroid hormone. This is the whole mechanism how homeostasis of calcium occurs. Now, as we discussed, the three hormones that will regulate calcium and phosphate are vitamin D, parathyroid hormone and calcitonin. How does vitamin D helps? Vitamin D is also called as cholecalciferol, and active form of vitamin D is 1,25-dihydroxycholecalciferol. Here what happens is, when the sun rays fall onto the skin starts producing 25-hydroxy-D. This 25-hydroxy-D will go into the liver, where it forms into 1,25-dihydroxy-D. Okay, there again we can from here what happens, now this 1,25-hydroxy-D will again go at the adrenal gland of the kidney, will form into 1,25-dihydroxycholecalciferol, which is nothing but our active form of vitamin D. Okay, here what happens, this vitamin D, that is nothing but the active form is 1,25-dihydroxycholecalciferol, will act on the mRNA, which will further act on the calcium binding protein. Thus there will be an increased calcium uptake from the small intestine. This is about parathyroid hormone. It is a single chain polypeptide, usually having about 84 amino acids with it, with a molecular weight of 9,000. Plasma life is usually 20 to 30 minutes, and plasma concentration is about 10 to 50 pg per ml, and it is usually measured by an immunoassay. Here, normally there will be the initial production is pro parathyroid hormone, which will actually have 115 amino acids, where by enzymatic deletion it will convert into pro PTH, and further it converts into parathyroid hormone, which is the final active product of the parathyroid glands. This parathyroid hormone has effect on bone, kidney and also on intestine. On the bone, what happens, it will cause osteolysis or osteoclastic bone resorption, leading to loss of calcium. And on the kidney, it usually acts on distal convoluted tubule, where there will be calcium reabsorption, and in the proximal convoluted tubule it will cause inhibition of phosphate reabsorption, and it will also stimulate hydroxylation of 25 hydroxycholecalciferol to 125 hydroxycholecalciferol within the kidneys. On the intestine, usually does not have any direct effect, but parathyroid hormone usually has this effect on vitamin D, where it is responsible for formation of active vitamin D, which is in turn responsible for absorption of calcium within the gut. Thus, parathyroid hormone has an indirect effect on the intestine. So, this is about the regulation. This is a picture showing calcium regulation, which we have discussed just now. And what is that which will actually helpful for stimulation of parathyroid secretion? As we already discussed, parathyroid hormone stimulation is nothing but by decreased serum calcium levels. Once the plasma calcium levels are decreased, it is plasma calcium. Once there is a low level of plasma calcium level, it itself acts as a stimulating factor for the PTH secretion. Once there is a maximum secretion, that is the plasma calcium level falls below 7 mg per deciliter. When plasma calcium level increases to 11 mg per deciliter, then PTH secretion will be decreased. Now coming to hyperparathyroidism. Whenever there is excessive secretion of parathyroid hormone, it is called as hyperparathyroidism, and this can be because of any adenomas of the parathyroid gland. And in the way it manifests as various clinical symptoms and signs, which include patients usually manifest bone pain, joint pains, they'll have stiffness of joints, pathological fractures are usually seen, and we can also see renal calculi, dystrophic calcifications. Patients will also manifest with peptic ulcers, psychiatric problems, and they may have multiple myeloma, metastatic tumors, but these are very rare in occurrence. And we also see increased serum alkaline phosphatase as one of the investigative feature in case of hyperparathyroidism. Coming to the dental findings, in case of hyperparathyroidism, we can see malocclusion because of gradual drifting of the teeth. And further increase in PTH, there will be loosening of teeth and gradual falling of teeth also can be seen, and there will be definitive spacing because of drifting of teeth. We can also see abortive attempts of bone repair and new bone formation can also be seen in these cases. Coming to the radiological features, in general radiologic features, there are subtle erosions of the bone can be seen, especially in the subperiosteal surfaces of phalanges of the hands. We also can see demineralization of skeleton, where we can see ill-defined radiolucent regions on the radiograph. Osteitis fibrosa cystica is a pathognomic feature of hyperparathyroidism. And we also have brown tumors. Brown tumors are nothing but well-defined radiolucent regions, which is because of osteolytic activity of the bone. And we also see pathological calcifications, especially in the kidneys, and which are usually punctate and nodular type, which will form into renal calculi. We also see loss of central diploid trabeculae and thinning of cortical plates. Here we see a picture where we can see brown tumors of the hands, and we also see these brown tumors in the mandible also. Coming to the radiologic features of the jaws, there will be thinning of cortical plate. Usually the base of the mandible cortical plate is usually thinned and we cannot see a definitive nice well-defined cortical border. Sometimes in severe cases, the cortical boundary of your mandibular canal can also be lost, or it can be visceral. Ground glass appearance of the bone is a pathognomic feature. It is because of randomly placed or increase in the number of trabeculae. We can see ground glass appearance of the bone. Loss of lamina dura is one of the pathognomic feature of hyperparathyroidism. It can be either localized or generalized. Most commonly generalized loss of lamina dura can be seen in case of hyperparathyroidism. Now coming to hypoparathyroidism. Hypoparathyroidism is a condition where there is decreased circulating parathyroid hormone. It can be due to any surgical removal of your parathyroid glands, or congenital abscess of the gland, or atrophy of the gland. The clinical features of hypoparathyroidism include paresthesia. Patients usually manifest with paresthesia. There can be neurological changes and reduction in the intellectual capacity, which is one of the pathognomic feature again of hypoparathyroidism, especially in the chronic hypoparathyroidism conditions. We have something called radiologic features again, where there can see calcification of basal ganglion, dental enamel hypoplasia, external root resorption, delayed eruption, and root dilacerations can be seen in case of hypoparathyroidism. Now, coming to calcitonin, which is another important hormone in regulation of calcium. Calcitonin, as we discussed, is a physiologic antagonist of PTH and with respect to calcium. Calcitonin is usually secreted by the parafollicular cells or C cells of thyroid gland. It is also called as thyrocalcitonin. The main effect of this calcitonin is rapid fall of plasma calcium levels. The target site is bone and osteoclast. Usually it increases the osteoclastic activity and there will be decrease in the ability of osteoclast to resorb, there will be decrease in the ability of osteoclast to resorb the bone. Here calcitonin, what it does is, it will prevent the action of osteoclast. Here osteoclasts will lose their ruffled border and they lose the mobility and they become they lose their function of osteoclastic activity. There will be decreased ability of osteoclast to resorb the bone. Coming to effect of other hormones, growth hormone also have effect on calcium regulation, where it will cause increased absorption of calcium. Insulin is also useful in formation of bone, and testosterone and estrogen in younger age group there doesn't have much effect, but estrogen in case of older age group, especially in postmenopausal women, there will be osteoporosis in those cases. Lactogen and prolactin also will cause increased absorption. And these are the various hormones that will actually, steroids and thyroid hormones also have their effect on calcium regulation. Now coming to excretion of calcium. Now we have seen absorption of calcium, its regulation within the body, and now coming to excretion of calcium. Usually calcium is excreted in feces 90% and even in the urine also. In intestine also we can see little amount of calcium excretion via the GI juices, gastrointestinal juices, and also from the mucosal cells which are rich in calcium will be shedded off, leading to excretion of calcium, that is non-absorption of calcium into the blood. Coming to the clinical manifestations, when there is increased serum calcium, when the serum calcium is increased, it can lead to hyperparathyroidism, hypervitaminosis, and we can see multiple myeloma, sarcoidosis, thyrotoxicosis, milk alkali syndrome, and infantile hypercalcemia. In case of decreased serum calcium, we can say renal failure, there will be hypoparathyroidism, vitamin D deficiency. Patients usually manifest with symptoms which conditions such as tetany, malabsorption syndrome, and long-term steroid therapy. When coming to hypercalcemia, the conditions that lead to hypercalcemia are again hyperparathyroidism and acute osteoporosis, thyrotoxicosis, and vitamin D intoxication. Various symptoms include tiredness, loss of appetite, nausea, vomiting, polyuria, dehydration, and loss of muscle tone. In hypocalcemia, the conditions that lead to hypocalcemia include insufficient dietary calcium, hypoparathyroidism, and increase in calcitonin. There will be insufficient vitamin D also in case of hypocalcemia. Tetany is one of the feature because of hypocalcemia, that is decreased calcium, which will lead to carpopidal spasm. They have a particular signs here, which is nothing but swastik sign, where there will be contraction of ipsilateral facial muscles when tapping the facial nerve over the angle of the mandible. That is called as swastik sign. When we tap the mandible, the facial nerve over the mandible, ipsilateral facial muscles will contract. Earp sign. Earp sign is hyperexcitability of muscles to electric stimuli. This is nothing but Earp sign because of hypocalcemia. And we also have Trosia sign. Trosia sign is spasm of muscles of upper extremity causing flexion of wrist and thumb and extension of fingers. Clinically, this can be produced by applying pressure with sphygmomanometer cuff on the upper arm. Now coming to heterotopic calcifications, in case of it is also one of the calcium disorder. These heterotopic calcifications are of three types, which include metastatic calcifications, dystrophic calcifications, and calcinosis. Dystrophic calcifications are usually those type of heterotopic calcifications that are occurring in areas which are previously inflamed or dead. Here, serum calcium levels are usually normal, but still there will be calcifications. In metastatic calcifications, there will be increased serum and phosphate levels, thus causing calcifications within the body. Calcinosis is a condition where there will be calcifications in the skin or subcutaneous regions. So this is about the calcium metabolism, how it is being absorbed, how calcium regulation occurs within the plasma and the bone, and how various hormones, especially the parathyroid hormone, vitamin D and calcitonin are helpful in regulation of the calcium metabolism, and their manifestations either in increased calcium or decreased calcium levels, how they manifest are being discussed, and this is about calcium metabolism and parathyroid hormone. Thank you.